Okay, no questions from the virtual participants? Dr. Atmasiri?
So now it's time for the third lecture. So it will be given by Professor Sir Sabarat Marulkumaran. He's Professor Emeritus of Obstetrics and Gynecology. Sir Professor Sabarat Marulkumaran is a Professor Emeritus of Obstetrics and Gynecology, St. George's University of London. Visiting Professor, Institute of Global Health Innovation, Imperial College London. Foundation Professor of ONG in University of Nicosia. Has been the Professor and Head of Department in ONG, National University of Singapore and University of Nottingham, Derby, and St. George's University of London. He is author of 300 index publications, author or editor of 38 books and more than 200 book chapters. He is the Editor-in-Chief of Best Practice and Research in Clinical Obstetrics and Gynecology, Emeritus Professor, Global Library of Women's Medicine, GLOWM. He is also the former president of the FIGO, BMA, British Medical Association, and the Royal College of Obstetrician Gynecologists. So Professor Sabarat Marulkumaran was awarded with the Knight Bachelor in recognition of services to the medicine and health services by Her Majesty of Queen, birthday honors list, June 2019. So I am honored to introduce Professor Sabarat Marulkumaran to you, and you all are lucky to listen to him on surveillance of maternal deaths and lessons learned. May I invite Professor Sabarat Marulkumaran to our podium.
Good morning. I would like to thank Dr. Surantha Pereira for inviting me for this meeting, and it's a great pleasure to join the annual Scientific Congress of the Perinatal Society of Sri Lanka. The given topic to me is surveillance of maternal deaths and lessons learned. In order to prepare this lecture, I read the WHO document on maternal death surveillance and response and had some help from Dr. Matthews Mathai, who is from the WHO in the past. In terms of objectives, I'm going to talk a little bit about maternal death surveillance, followed by lessons learned. And at the outset, I have no interest to declare. This is a global map of maternal mortality. As you could see, the darker colors indicate high maternal mortality, and these are the countries which are going to benefit maximally by having a maternal death review and surveillance and taking action based on what they find as suboptimal care. So what is maternal death surveillance, lessons learned? Well, we had to learn the lessons in order to provide the best response and to take key actions that are effective in reducing maternal deaths. So it is a form of continuous surveillance linking the health information system and the quality improvement processes from local to national levels. It includes the routine identification, notification, quantification, and determination of causes and avoidability of all maternal deaths. The use of this information to respond with actions that will prevent future deaths. So we have to convert the data into meaningful information so that we can find out what were the deaths which are available and what should we do in order to reduce these maternal deaths. Now there are various definitions, and I like this one by Daniel, Graham, and Boerma. A maternal death surveillance and response systems that includes maternal death identification, reporting, review, and response can provide the essential information to stimulate and guide actions to prevent future maternal deaths and improve the measurement of maternal mortality. So maternal death, S, MDSR, the S focuses on surveillance for a rare but important problem, and R focuses on the response, the action portion of the surveillance. MDSR builds on maternal death reviews which has been done in the past and underlines the critical need to respond to every maternal death. Not a group of maternal, but every maternal death can be responded by taking this review. So to count every maternal death, permitting an assessment of the true magnitude of maternal mortality and the impact of actions taken to reduce it. So we have to be cognizant of the fact that every maternal death will teach us some lessons, and there might be something special for that, or collectively few maternal deaths might give us a lesson. So to provide the information that effectively guides action to end prevent maternal mortality at health facilities and in community, because some recommendations might be applicable to a facility or to the community. And MDSR is an important lesson we have to really keep reminding ourselves to reduce maternal deaths, because it is the goal set up earlier by the MDG and now by the SDG that we need to achieve. And ending preventable death requires better measurement, and country ownership of data in real time would help achieve this. And MDSR makes maternal death visible at local and national level, provide information at local, health facility, and district levels, and provides information to action to prevent deaths, and sensitizes communities and facility health workers, and connects actions to results, and permits measurement of the impact. So it has to be a continuous audit cycle, and successful MDSR helps to strengthen national civil registration and vital statistics and quality improvement and other health information systems. For MDSR to be effective, maternal death should be notifiable event to give greater visibility and highlight the importance, and identify all maternal deaths at facility level or community level, but we can take a phased approach depending on the help you have and also depending on the economic development of the country. Greater emphasis on response and accountability for response. So we have to pay not only attention to identifying the problems, but also what is the response, and did they act according to the recommendation of the response, and did it work? So we have to monitor and evaluate success of MDSR. And MDSR can be built on existing systems. We don't have to start all over new systems, but we can have maternal death reviews at the moment. We just change it into surveillance response and find out whether the response are working. In a diagrammatic fashion, this audit cycle is given here: surveillance, identified deaths, and that is vital registration. Then report the deaths for maternal mortality rate tracking, and provide the response either as individual cases or as a group of cases, and review the deaths in order to identify what is the quality of care you can improve, and then you put it on action, response action, and see whether there is quality of care improvement, and then do the surveillance all over again. So it is a process. Identify deaths of all women of reproductive age group, and there might be some probable deaths we are not very sure, but we have to find out. Notify the authorities, review all probable deaths, and identify the causes, find the contributing factors, and include it under the quality of care. So the most important thing is to respond for each maternal death and recommend some implementable actions, not some blue sky action, but implementable action based on the environment. And aggregate the cases, not one, you might find some recommendation, but you have to aggregate some cases together and get a group recommendation. And you can publish this as an annual report, which is facility-based or district report. And the monitoring and evaluation of the MDSR system must be continuous. Now to start with, you can take the horizontal axis. You can find the place of deaths. So it might be in government facilities to start with, then in the community, then in all facilities, and you can build it up for the whole country. Or otherwise, you can take it as urban areas, then districts, and then national coverage. And summary of sample deaths can be taken if the number of deaths are too many, you won't be able to identify and investigate into every case. So you can take a sample of deaths or summary of all deaths and in-depth inquiry of a sample, and you can come out with a full confidential inquiry and recommendations based on that. Now, the maternal death review has been in the UK, and there have been reports published every 3 years from 1952. And in 1952 to 54 report, there were 1 in 1,500 births, there was a maternal death. Now in 2008, 1 in 30,000, now it has gone to 1 in 25,000 or 35,000. And generally, these reports provide some recommendation to produce new guidelines and new training and skills training. And if you convert that to global, the confidential inquiry in the UK has suggested the death rates were 13 per 100,000 and then 10 per 100,000 nowadays. But globally, there are 300,000 women die. And the general knowledge we gain from that is you can avoid 30% of maternal death by providing contraception, 15% by safe abortion care, and the balance by giving emergency obstetric care. So there are 3 baskets of care: contraception, safe abortion care, and emergency obstetric care. Now, one of the important things to recognize is that all these reports say 60 to 70% of maternal deaths could be avoided because there is suboptimal care in those cases. Just as an example, one of these triennial reports shows that venous thromboembolism, there is 57% substandard care, preeclampsia 50%, and anesthetic deaths 100% because probably they found it difficult to intubate or the configuration of the patient was not recognized and assessed to start with. But in all the causes put together, 67% were substandard care. So what does the Royal College do and the NICE guidelines do? They produce guidelines, appropriate guidelines to implement and improve practice. This is one of the latest guidelines on maternal collapse in 2019. During the time I was a trainee, thromboembolism was one of the main causes. Women come, they have peripartum collapse postnatally or antenatally, and it was the commonest cause of death in 97 to 99. And there were 31 deaths. 17 occurred in post-delivery. So what did we do? They introduced guidelines to diagnose pulmonary embolism. These are central chest pain, pleuritic pain, sudden onset. If massive pulmonary embolism, there's collapse and cyanosis. So they said, get on and do a pulse oximetry to see the oxygen saturation, ECG to look for right ventricular strain, and then when the patient is settled, do a ventilation perfusion scan to confirm or a spiral CT. And the signs and symptoms were well recognized, like tachypnea, dyspnea, pleuritic pain, apprehension, cough, and at a specific point there is a pleuritic pain, there is rhonchi and Krebs. And you do an ECG to find for right ventricular strain, and you do a VQ scan where it'll show there is a deficiency of ventilation where there's a pulmonary embolus. And if it is a subtle thrombus where they have collapsed, and in most hospitals with radiological facilities now, they have facilities for dislodging this clot. So you can start the treatment, which is therapeutic or heparin dose, oxygen IV fluid, and streptokinase or alteplase to dissolve the clot, and embolectomy by percutaneous catheter procedure. So you can see a catheter being passed and it is being dislodged. So guidelines and also shaping the facilities to provide has reduced the incidence of deaths due to pulmonary thromboembolism. Now I'm going to talk another topic which can reduce maternal deaths, that is adequacy of staff, their training and competence. This was a story of Northwick Park Hospital in 2005, 2006. There were 10 maternal deaths in 3 years. That was far in excess because 10 maternal deaths should be for the whole of 100,000, whereas 3 years was 15,000 deliveries in Northwick Park. So they asked me to come and have a look, and we went and investigated what was going wrong. And one of the things we found, as you could see from the 4th or 5th column, lack of consultant input in 6 out of 10 maternal deaths. So there was a problem, either there's not enough consultants or consultants are not on duty, or the staff finding it difficult to convey the message that the patient is so serious. And one of the main causes of postpartum hemorrhage, so this chart was produced at Queen Charlotte's, and as you could see, the blood is soaking from the bed. It is on the ground, it's more than 2 liters, but if it is on the bed, 1,000 to 2,000 liters. Now this is actually publicized. This is a nurse who had a cesarean section at full dilatation, and the blood loss was 1,500 mils. And they informed the consultant, and the consultant asked, is it for information or they want me to come? So the message going up and down is not very clear, and also the general condition of the patient is not conveyed when you say blood loss of 1,500 mils. Anyhow, the consultant said, I'll come, but get the blood ready. So by the time the patient was operated on, patient was in serious condition. She was a nurse in that hospital and she died. So one of the things the college did during my presidency was to bring about some good practice guidelines. And we said there should be a responsibility of the consultant on call. And if there is major postpartum hemorrhage, don't ask any question, just go in. Same with collapsed patient, return to theater for laparotomy, or if the trainee, ask the consultant to attend, because it's quite important, there is a serious problem. Now I mentioned there's a problem in recognition of the seriousness of the patient. So this is a typical example. This lady had a cesarean section, and at the recovery in the postnatal unit, she said, I'm going to die. She was breathless. I have difficulty in breathing. There was rapid pulse. Her sister was a doctor, and she said something is going wrong. The midwife and the junior doctors looked. There was no overt bleeding outside, but what was happening was she was bleeding inside the uterus, and it was accumulating. Although the pulse and blood pressure was showing signs, it was not picked up. So that's the time we thought of modifying the obstetric early warning score chart. The major difference from the pulse, temperature, blood pressure chart or respiratory chart here is actually to color code it. So when a parameter is plotted in the red, you call for the senior help. If it is in amber, the registrar. If it is red, the consultant must attend. And if it is 2, then the urgency is much greater, within 15 minutes or so. And the major difference between the standard early warning score chart and the obstetric early warning score chart is the systolic blood pressure is plotted separately, as you could see here. In this one, the heart rate, temperature, and respiration is plotted. In the other one, the systolic is plotted separately from the diastolic blood pressure, because the same chart can be used for hypertensive disease or for postpartum hemorrhage. And if you observe this very carefully, if the parameters move by 30, either blood pressure or pulse rate move by 30, that means the patient has lost 30% blood loss. So that is one way of identifying. But not only it's important to identify things are going wrong in the observation, but also how to inform. So we introduced this following the general medical and surgical principle to use a communication tool called the ISBA. Identify who you are and where the patient is. Explain the situation, what is happening. Explain the background, that she came in labored for so many hours and so on. Your assessment, which means the pulse, blood pressure, etc. you have mentioned earlier, but your assessment is she is in a state of shock and so on. And what is your recommendation and what should be done? And in terms of postpartum hemorrhage, which was quite evident, that we must keep the hemoglobin more than 7 grams, because if it is more than 30% blood loss, she should be given blood and plasma at equal levels. And one of the simplest things which we forget is to have a broad or large bore cannula, which is 14 or 16 gauge cannula on both arms, because that is the orange cannula, which can give 240 to 300 mL per minute. Gray is 160 to 200 mL per minute. So in obstetric units, it is better not to use smaller cannulas because you can't give enough fluids or blood. Now I mentioned about Northwick Park Hospital, and the consultant did not come in 6 out of 10 cases. And partly it might be because there are not enough consultants, or they are working from home. This is like a surveillance plane from Monday or Friday evening 5 o'clock till Monday morning 9 o'clock. Nobody is there. they manage the cases by phone. It's like a surveillance plane. Like if you get into the plane and the pilot announces, I'm at home and my trainee pilot will take you across from Sri Lanka to London, then you will get down from the plane. So the same way, we had to increase the number of professionals who are available immediately. Either they are on duty or they should be available within minutes. So this was a major issue. I took it up with the politicians by publicizing in the papers. And I mentioned health and safety of both pregnant women and babies are being put at risk because there are too few consultants on duty, and maternity units do not employ enough to ensure the patient receive proper care. So the government expanded the consultant numbers. So in most larger units, we are 24/7 cover now. Now, another issue is actually we have to adopt a new medication so that we can reduce maternal death. This was following a large study called the Women Study with 20,000 patients. I chaired the steering committee, and tranexamic acid, if it is given within a short time, within 3 hours, it will reduce maternal death. So WHO came out with recommendations, regardless of whether it's atonic hemorrhage or genital tract trauma, give tranexamic acid within 3 hours. And you give 1 gram slowly IV in over 10 minutes. And you can give another dose 30 minutes later if she continues to bleed. You have to take some precaution because if you give it bolus as a rapid injection, it will lower the blood pressure. And also, most IV solutions, you can give it with electrolytes, carbohydrate, amino acid, because it is compatible, but do not mix it with blood and penicillin and mannitol, they might have a reaction. So should not use if there's a contraindication for antifibrinolytic, including known thromboembolism. It doesn't promote thrombosis, but it prevents lysis of the clot. So you want the clot to be stabilized in the uterine vessels. Now, the same cases which died in the woman trial, 483 women, we did a study. And the predominant reason why these women died were because they were transferred from outside, so they were late presentation. The second thing is maternal anemia. So it's quite important that the woman is not anemic before she starts in labor. Thirdly, availability of blood transfusion. And fourthly, poor infrastructure, which means not enough personnel, training, etc. So we had to, in Sri Lankan context, this is not a major problem, but we must make sure the women are not anemic before they come to 34, 35 weeks. They should be given iron and folic acid if needed, anti-helminthic treatment, and so forth. Of course, we can really prevent before the catastrophe happening by monitoring the events, the severe clinical incidents, the near misses. I think Dr. Anoma Jatilaka is going to talk about it, or has spoken about it already. And you can monitor these by having a maternity dashboard. Essentially what we did was to plot the difficult cases, the actual incidents and so on. It is like a car dashboard. If the oil or petrol goes down, nobody takes any attention. But if it happens, it goes into the red zone, we start panic and taking some action. So the idea is actually to plot the number of deliveries in a unit, number of consultants, number of midwives in a unit to see whether they're optimal. That's the first column. The second column as a group is actually the total number of cesarean sections, operated delivery. And the third is actually adverse incidents like PPH, admission to ICU, admission of babies to neonatal unit. And the last is actually complaints and risk incidents. So we have a zone. Green means there is nothing to worry. Amber means, well, things are going up, so we have to make a note. Red means something dangerous has happened and we have to take action immediately. And if necessary, you have to go to the chief executive or medical superintendent and get action needed. Now, we are always focusing on medical issues, but we have to be careful about avoiding maternal death rather than trying to rescue when the patient is falling down the cliff. That is PPH, preeclampsia, thromboembolism. So we did this report through Imperial College, and we found there are 3 baskets of care which will help in reducing maternal death. 30% can be reduced by contraception, and 13 to 15% by safe abortion care, and the rest by emergency obstetric care. And globally, as you know, there are 289,000 deaths at the end of 2015, but there are 225 million women without family planning. So if we can provide family planning, that'll be a good thing. As you could see from the picture, there is an unmet need of family planning based on the MDG5. And we can give voluntary family spacing by postpartum family planning programs, including long-acting reversible contraceptives. Sterilization should not be the main mode of postpartum contraception because these women are young, they might want to have a child a few years later. And the efficacy of Jardel or Depot or copper IUD is as good as female sterilization, so why not offer that? And we are happy with the FIGO worked with the Sri Lankan College in offering copper TAT, which can be used for 10 years, but you can take it out 2 or 3 years later. And there are only few expulsions and no perforations because the uterus is thick and they don't perforate. So I think that is something, postpartum contraception is something which we have to keep in mind. The next is about abortion, which is a human drama. I know that it is illegal in Sri Lanka, but we have to think about it very seriously because the numbers are not going down. These are from the UNFPA in 2009, 600 to 700 abortions, and majority of abortions are unsafe. And this particular report mentioned that the highest number of women having abortion are 35 to 39, and even 15% of emergency admission to gynae ward is related to septic abortion. Now the genie might be out of the bottle because women might be able to get mifepristone and misoprostol over the post, and the abortions might be coming down. But why should they do it in fear? We have to think about seriously whether we should liberalize abortion or legalize abortion. This is a story from Ireland. There was a mother, Savita Halapanama, who died, and the women were up in arms going along the protesting. And I chaired the inquiry and I said of various recommendations, the abortion law should be reviewed. And one of the recommendations was that if it is under 12 weeks, the chance of a woman dying because of termination is 0.1, 1 per 10,000. Compared to if the pregnancy continues, then it is 10. So 10 per 100,000. So in other words, the case fatality rate with legal abortion is small, and also in many countries has shown the abortion rate come down with legalizing abortion because you provide contraception. If they go for illegal abortion, contraception is not provided. So we did a survey among the Citizens Bureau under what conditions will they allow abortion. If it is physical or injury to the health or life of the mother, almost 98% said they will allow abortion. And if it is incest or rape, they said about 80% said they should offer abortion. So there were different conditions for which people supported in Ireland. And these were done by professional organizations, these survey, especially on Citizens Bureau. And the last column is if there is no medical indication, would you offer abortion? 65%, and this went up to 85% or 80% if it is under 12 weeks. So that was put to parliamentarians and there were a referendum, people went and voted, and by 66% it was legalized in abortion. And this is the scene after the voting was done, and they call it Ireland's Journey to Care, Compassion and Choice. Now, it is quite important for professional organizations who are looking after women's health to consider this seriously. I know there are religious issues and so on. There are two issues because by not legalizing abortion, the number of abortions are not going to go down. Sometimes I say I support legal abortion. If you don't support, you are supporting illegal abortion in some way. So that is something, I don't know the current figures of how many deaths happen due to illegal abortion in Sri Lanka, but something which we have to take into consideration. So in concluding, the maternal death survey is a continuum. Use surveillance, identify the deaths, report the deaths, respond, review the deaths again after responding, and see whether the response action need to be improved. So in the UK, as I mentioned, the new guidelines are postulated or formed every time we have a maternal death review. Some of the examples are DVT and pulmonary embolism, postpartum hemorrhage, sepsis. Then there is training to cater for that. It can be not only obstetrician, radiologists. New medications have to be adapted, like tranexamic acid. Contraception should be part and parcel of the armamentarium by the obstetrician, and safe abortion care, and including mifepristone and misoprostol, which can be given under 9 weeks. Staffing numbers have to be reviewed, and competency of the staff has to be geared up by professional organizations like the Sri Lankan College of ONG. And change in policies has to be considered seriously, and I mentioned about abortion in some way. So I would like to conclude by some statement by Thoraya Obaid, who was the executive director of UNFPA some time ago. It keeps startling me that at the beginning of the 21st century, at a time when we can explore the depths of the seas and build an international space station, we have not been able to make childbirth safe for all women around the world. This is one of the greatest social deficiencies of our time. And she continues to say, it is unethical not to take action to rectify this human rights issue. I would like to thank you for patient listening and giving me the opportunity to share my thoughts on these subjects of maternal surveillance and response. Thank you very much indeed. Thank you.
Thank you very much, and I think that was an online recorded presentation, so we cannot take questions on that. But if there are any questions throughout for all presentations presented today, because this is a very important topic and a very sensitive topic, I think
I must thank all the speakers, very informative, and the speech from Professor Sabaratnam sir also. And the question is, all of us know the near misses and maternal death need to be reviewed. The reviewing process, by reviewing, we learn a lot, and measures we have to rectify. So this question goes to Dr. Pradeep Disila sir. So when we review the process, what do you think is the best for Sri Lanka? Being confident, because I think review process should be there. It's a long process. A certain section is open. So open versus close, and what is the way forward? The question is for you, sir.
It's a very, very timely question, because we are in the crossroads of developing something unique for Sri Lanka. So the suggestion that I'm saying is, what is the council's decision of the SLCOG with regard to this? So what we have suggested is, actually the confidential inquiry should go, that should be a process where a national statistics would come out with recommendations. But similarly, we are asking the institutional inquiry to be strengthened and made a learning process for that institution, where the problems which are not national level are tackled at that moment. But sadly, what happens is, we have all these things, nothing has changed. See, you say the SHOs have not been there. So I'll give a small example. In a base hospital close to Kandy, a patient comes with little bit bleeding and pain. The patient comes on a Sunday morning, and the patient is kept till Monday to do the cesarean. And the outcome is bad with regard to the perinatal part. Mother, of course, okay, but the other thing also could be possible, because the access to the cesarean section was a issue in the institution. It needs not to be brought up to in the national level, but that will never get corrected in this way. So if you give very important things, such as what I said, is lack of infrastructure of the labor room and things in a national manner, then it will get corrected. Otherwise, they will never get corrected. So, coming back to your question, the answer is we must have, we must not confuse these two modalities of investigation. If there's a maternal death, there's 3 forms of investigation even now. One is this our inquiry of maternal death as we go, saying no fault, no blame, nothing, and no action. I add that also. We have that. So the next thing at the moment available is a complaint by the parties and a departmental inquiry. That's a completely different thing. Third thing available right now is a civil litigation process. These 3 are independent. So what we are suggesting is only the first one, that which has not shown any good effect for the last 10 years. We must change. We must change in order to find why it is really happening, because we have participated in that. You can't be criticizing your own people, even you see something wrong, because you have affiliations and connections and relations, things like that. So therefore, this making it anonymous and analyzing for the sake of the country is very important. But with regard to the hospital, the incident, that has to be analyzed in a different manner, where action will be taken to rectify whatever the deficiencies which are local level ones.
Thank you, sir.
To add to that, I think, whatever the measure of analyzing the maternal deaths or morbidity, the main purpose should be to reduce them individually. That's whole country, institutional or district, there may be variations, but the target team effort should be to minimize them from the beginning.
So when it comes to near misses, do we have a mechanism right now to talk about near misses?
No, we have a mechanism, but it's not in the full form at the moment, but we should expand it. But we also know the reasons for most of these near misses. And I gave a lecture yesterday again to the audience of midwives and nurses. Majority, the main reason is the system failure. So it's more than 60-70% is system failure. The rest are further down. So if we can improve the system, whatever the failures that we have in institutions or in the national, the misses also. Now, sometimes we create near misses when we don't apply whatever the available knowledge or the method of management when it is at a lower level. So sometimes near misses are created. It's not now. If you don't treat prophylactically for eclampsia or treat the hypertension, then it will end up with intracranial hemorrhage or eclampsia. So that will be a near miss. So when we analyze near misses, we know the reason why it has come most of the time. So it is the basic application of our management system. Now, sometimes, as we mentioned, some are preventable, some are non-preventable. So we have to see what are the preventable ones, even in the near misses, not to go to up that state.
I think this concludes our symposium on maternal near misses and maternal death. So thank you very much for your kind participation for this.
Thank you all for dedicating your time in delivering those enlightening presentations. It's now my pleasure to invite our chairpersons, Dr. UDP Ratnasiri and Dr. Asri Heva Malike, to present a token of appreciation to our esteemed guest speaker, Dr. Pradeep Silva. Now I would like to invite Dr. Suranta Pereira to present with a token of appreciation for our chairpersons. Thank you, Madam. For our second symposium, I would like to invite upon stage Professor Dulani Gunasekara, Professor of Pediatrics, Dr. Nalin Gamathige, Consultant Neonatologist at Desoiza Hospital for Women, to chair the session.
Good afternoon, everyone. Welcome you all to this second symposium of the day. This is going to be a neonatal symposium involving novel therapies in newborn care. And in that, we have three very important topics, namely prevention and management of pain, therapeutic hypothermia and CFM monitoring, and nitric oxide therapy. Now, pain is not a new thing in neonatology or for that matter in medicine at all, but unfortunately in the area of neonatology, pain has been addressed rather poorly. So I think it is now very timely a topic to address, because newborn babies also do get pain, do experience painful stimuli. So to talk about that, we have a virtual speaker online. He's Dr. Hector Boer, followed by two novel therapies, therapeutic hypothermia and CSFM monitoring, and nitric oxide therapy in PPHN. These are two very novel therapies, especially in the Sri Lankan perspective. It's only a few years ago that we started these two therapies. And these were started, first of all, in Castle Street. And I think it is timely that two experts from Castle Street, neonatologists, are there to speak to us. Therapeutic hypothermia and CSFM monitoring. This talk will be done by Dr. Suranta Pereira, consultant in charge of the neonatal unit, and followed by nitric oxide therapy in PPHN. Also, both are from Castle Street. And the second topic will be done by Dr. Saman Kumar, a neonatologist in Castle Street. So I have the honor of introducing the first speaker to talk on the prevention and management of pain. He is Dr. Hector Boer Alonso, who is a pediatrician specialized in neonatology at the Children's Hospital and Women's Hospital in Val-d'Hebron Research Institute of France. He is interested in neonatal neurology and the adaptation of extreme premature babies to extrauterine life. He is a member of the board of the Spanish Society of Neonatology and is also a member of the European Society for Pediatric Research. So may I now invite Dr. Hector Boer Alonso to please come online and deliver his lecture.
Well, good morning. Thank you very much to the organizers for inviting me to give this talk. I will talk about pain, stress, and comfort. I do work in Val-d'Hebron, but Val-d'Hebron is in Spain, not in France. I'll start just with the definition of pain that the International Association for the Study of Pain gives. And they say it's an unpleasant sensory and emotional experience associated with, or resembled associated with, actual or potential tissue damage. There are several key points that this association makes, and I wanted to highlight three of them. One of them is, the first one is that pain is a personal experience that is obviously influenced by many things, like biological, psychological, or social factors. But what I find important as well is that pain and nociception are not the same. Nociception would be all the sensory neurons that are the pathway that leads all these sensory feeling, let's say. And pain, it involves as well the emotional factor of it. But what is really important for our patients that are newborns is that the verbal or even the non-verbal description is only one of several ways of expressing pain, meaning that if the baby is not moving or is not crying, that doesn't mean that he's not feeling pain. We do know that pain is a huge problem in our neonatal units. With this classic study by Carvajal, we could see that every single day, all our neonates in the NICUs are exposed to at least 16 procedures that involve pain, stress, and or stress, like the examples I just gave on that side. So it is a huge problem that we have to address. There are many different pain scales to measure pain, and they do a fantastic job. They are very good for what they are capable of measuring. The first couple of them here in this list are probably the most used the most used pain scales, but none of them has prevailed over the others. And that is basically because they have many problems. They're mainly focused on identifying the behavioral or the response that the baby has to pain. And plenty of times, this response is going to be masked by several things that I will mention in the next slide. So what problems do we have? Gestational age. A 24-weeker is not going to behave, is not going to respond physically. The motor component is going to be very small compared to a term baby. Or if the babies are sedated. So looking at the reaction that the baby does to a pain stimulus is probably not the best way of measuring pain. These scales need that the staff is trained in using them, and the problem is that they are all designed to identify instant pain, but not to monitor pain. Let's say in a post-op situation. So they just give you a photograph of how the baby is in the moment that you're passing that pain scale, but it's not a monitor. So the problem is that with trying to identify pain in a baby, there's no gold standard. There's nothing we can compare these scales with, or any machine that is designed. There's no gold standard, so we can't know exactly if it works well or not. And on top of that, we have to remember that we are dealing with babies of different gestational ages, and their organs are not well mature, and the autonomous nervous system is going to be very different in a 24-weeker than in a term baby. Or the neuroendocrine response to stress. Acute versus chronic pain. So what I'm trying to say is that pain is far more complex than it seems, and even more in a preterm baby. So maybe what I propose is to start looking more to stress rather than pain. Pain, as we've just been mentioning, is difficult to identify, but stress may be a little bit easier because we have objective ways of measuring stress, as I will address in the next slides. But the problem is that talking about stress is talking about autonomous nervous system, and every time I mention autonomous nervous system to my juniors, they just go bored. They want to listen about PDAs and mechanical ventilation. So it's a little bit like the ugly duckling of neonatology. But all those organs that I've just mentioned, PDA, mechanical ventilation, so lungs, heart, etc., they're all controlled or managed by the autonomous nervous system. So the sympathetic and parasympathetic nervous system are a key feature that we tend to forget about. So if we remember when a baby is at at rest, their parasympathetic activity is just slowing down the sympathetic. Therefore, respiratory rate goes down, heart rate goes down, and the baby is more calm and relaxed. In a stressful situation, just the opposite. The sympathetic takes control. The tachycardia comes in, increased respiratory rate, sweaty hands, and all this. And if we go to the extreme, the fight or flight situation, then pure sympathetic activity and increased sympathetic activity takes full control of the situation. But what we've been told, even though it's not 100% correct, but we've been told that the autonomous nervous system, there's harmony, there's synchrony between sympathetic and parasympathetic. When one goes down, the other one goes up, and the other way around. So can we measure the parasympathetic activity or the sympathetic activity? Yes, we can. And these two ways of measuring it have been validated in the last few years. Many studies are being done looking at heart rate variability and skin conductance response. I'm going to focus on heart rate variability as you will see. So the heart rate variability, as you may remember, there is this respiratory sinus arrhythmia. When we inspire, the heart rate goes slightly faster than when we exhale. So taking this into account, what we can do is we can measure the milliseconds that go from the R to R interval in the QRS complex. And as you can see here, when during inspiration, it goes down to 145 milliseconds, and expiration goes 870 milliseconds. Well, measuring the distance between these QRS complexes, what you can see is the variability, the heart rate variability. And when you look into that, you're gonna see a graph like this, and you're gonna have very low frequency, low frequency, and high frequency heart rate variability. The very low frequency is influenced by thermoregulation and the endocrine system. The low frequency is sympathetic. It's a mixture of sympathetic and parasympathetic. But the high frequency, which is very interesting, is just regulated exclusively by the parasympathetic nervous system. And that means that devices like this one that focuses on high frequency heart rate variability are going to be able to measure parasympathetic activity. And how does it work? Well, what it does, it gives us a view of, it translates that signal into a percentage, meaning 100% percentage will be pure parasympathetic activity, and 0% will be pure sympathetic activity, right? And remember the harmony and the synchrony between the two of them. Therefore, what we're going to see on this device is that we do have a baseline until we have a stressful stimulus. Then the parasympathetic activity drops down and is more sympathetic until that stressful stimulus finishes, and then it goes up again to the baseline, right? You may have noticed that as a stressful example, I've just put breastfeed. Well, I know that for a pediatrician, a baby breastfeeding is probably the most calm, quiet, and relaxed baby you can think. And it probably is. But the autonomous nervous system at that point is actually under stress because the baby is trying to coordinate suction, swallowing, and breathing without making mistakes. So it is under stress that obviously is going to change over time, the amount of stress that means to a baby. So let me give you a real example. This is a study we did in my unit, and we were trying to compare the analgesic effect of saccharose, breast milk, and placebo before doing a stressful procedure that it was inserting an NG tube, right? So what we did in this case, this was one of the first babies we put in this study, and this baby was randomized to saccharose, and we gave saccharose. A couple of minutes later, we inserted the NG tube, and what we could see is that there was a slow increase on the parasympathetic activity. So the saccharose, it looked like it was working. At the peak of the action of the saccharose, we inserted the NG tube, and it went down the parasympathetic activity and slowly started to come back to the baseline. Right. At that point, we were just looking at the graph. It was one of the first babies, very excited. Look at this, it just gone up about 10% and down. And then the nurse asked us, have you finished with the experiment? Can I carry on with the baby? And we said, yeah, of course. Just carry on with your things. And then this happened. And we look at the monitor, we say, what's happening here? Is the machine gone wrong? And we look at the baby, and the nurse, what she had done when we finished this study was to put the baby on kangaroo care, skin to skin contact with the mother. And that increased their parasympathetic activity up to above 90%, which was extraordinary. We were looking at an increase of 10% with saccharose, but what was really potent was skin to skin care and kangaroo care. So we have to remember that we are neonatologists, and we don't deal with fully grown organs. We're dealing with organs that are growing, and that includes the autonomous nervous system. And what implication does that have? I mean, in a 24-weeker, is that the same as a 40-weeker? Well, as I said earlier, no, it's not. And we do know from animal studies that the first system to mature is the sympathetic, and then along the second and third trimester is the parasympathetic, the one that is maturing and increasing its activity. So what we can see in this study is that what they did, it was through the skin of the mother, pregnant women in the end of the second trimester, beginning of the third, and end of the third trimester, they measured the high frequency heart rate variability in normal pregnancies with no problems. And we could see, well, what we can see clearly is that the parasympathetic increases its activity, as I said earlier, end of the second and through the third trimester. What does that mean in the graph, in the machine I showed you earlier? Well, that means that this baseline will be the older the baby, or the more gestational age the baby has, this baseline would be higher and closer to a more parasympathetic activity, right? So we would start higher or lower according to the gestational age. And that is what we know from in utero studies. So what happens with premature babies? Well, this study was done expecting to see the same thing that we saw in utero. And I'm afraid that that's not what we saw. What happened in this study, here you can see 25, 26, 27, up to 31 weeks gestational age babies. And they had the heart rate variability measured in the first 24 hours of life. And here we have the term babies that acted as a control group. Well, the term babies had a value of 162. And what we can see here is that 25, 30 weeks, it's all 0.7125 up to the 162. We're really far away. And there's no progression. They all have more or less the same values. But that is concerning. But what's even more concerning is how did they evolve through their stay in the neonatal intensive care unit. The black dots is where they were born, and the lines is the progression that their heart rate variability had through all these weeks. Here we have the control groups, and we should be expecting that these lines were all heading towards that point where the control group are, but they remain very low. And what does that mean? How do we interpret all this? That means that these babies are exposed to a huge amount of stress when they are born, independently if they are 25 or 30 weeks. The amount of stress is so high that their response ability is very, very diminished, and they can't cope with it. But not only that, is that stress is maintained all through their stay in the neonatal unit. Therefore, what we're doing is we're stressing these babies non-stop since the day they were born. Uh, and even more concerning, when they are ready to go home, their parasympathetic activity is very immature, and that is gonna have an impact on their outcome. Mm, I'm a very positive person, and I think, and I want to think, that this study that was done in 2007, today, that we are moving from babies looking like this to a different type of neonatology. We're moving more towards this, where babies are contained, are we are looking at all the looking after all the stressful things that can affect the baby, like noise, light. We cocoon them, and we put them in a contention, and a lot of kangaroo care, skin to skin. I want to think that today, that study done on 2007 would would have much better results. And can we do anything to improve that parasympathetic activity? Well, exactly what I was just saying. What we've been doing. Many studies have been looking at the changes in the parasympathetic activity in babies who are exposed to kangaroo care or to skin contact. And what we can see is that uh, here, for instance, before skin to skin contact and after skin to skin contact, what it does is it increases the heart rate variability. What this means is that what we are doing is with all these things that have been introduced in our neonatal units, just like through common sense of minimizing stress, pain, kangaroo care, skin to skin contact. What we're doing is we are seeing that it works. And let me give you another example. In this is a study with term babies uh, after transposition of the great arteries correction. So 2 weeks, this is the group of breastfed babies, 2 weeks after the surgery, sorry, 2 weeks of age, they normally have all had their surgery done. And these babies, after this surgery, normally are very slow to learn how to feed. And here we can see that at 2 weeks, when we look at heart rate variability, we don't have that V-shape curve that you have when you have this stressful procedure that is breastfeeding. And you can see that the baseline is very low, right? When the study was repeated at 2 months of age, what you could see is that the baselines have gone up, that you do have a more healthy V-shaped graph, and the baselines are higher. So the baby has been learning, that parasympathetic activity has improved. But what happened with the group of babies that were bottle fed? Well, what it happens is that at 2 weeks of age, they, exactly the same as the breastfed babies, they have no clue of how to feed, right? The graphics go the wrong way around, and the baseline is low. But when you retake at 2 months of age, you get very similar abnormal responses to stress. So they have not learned much, or their parasympathetic activity has not improved much compared to the breastfed babies. So breastfeeding is not only good because of the milk, is also good because that bondage of that contact mother son, it actually helps improve their autonomous nervous system. So all these, what is proving, is just validating the model that, as I said earlier, is entering our neonatal units in the last few years. Skin to skin, kangaroo, minimizing light, noise, stimulating the presence of fathers, mothers, brothers. All these helps the baby to improve their autonomous nervous system. And okay, so this is how everything matures and what can we do? But what about pain? Can we monitor pain through these kind of monitors? Well, the answer is yes. Here, as I said earlier, the problem is that there's no gold standard we can compare this machine with. But if we compare with the things we have, that is pain scales, you can see that EDIN is a pain scale where being above 5 means pain, right? And here you can see that when you have an EDIN below 5, there's a good heart rate variability. And when the EDIN is 7, that means pain, there's hardly no heart rate variability. So it correlates very well. It obviously depends, there are some machine issues regarding the length of the painful stimuli and the response of and the accurate response of the machine, but they are very, very useful. This is another example in children under 3, but there were some newer babies as well, and well, basically it does work. So we use it in my unit. We use it to monitor comfort, and a baby that is on CPAP and has a stable baseline. When that baseline starts to go down, we go to the baby and look, because normally we find an IV line that is not working anymore and is painful, or is starting to have an injury in the nose because of the CPAP. So it is very useful to measure comfort. But we have to remember that we are monitoring autonomous nervous system. And that means that autonomous nervous system or parasympathetic activity is not only pain, it's many other things. If you remember that most of the vasoactive medication or the sedation is actually acting on the receptors of the sympathetic or parasympathetic autonomous nervous system. That means that if we are able to measure parasympathetic activity, we can titrate doses like sedation or vasoactive medication. So, and I won't go into the immune reflex, but if any of you is interested in reading about it, it's very, very interesting to see the involvement of the autonomous nervous system in the immune system or the immune response. But basically, just to finish my talk, one of the things we have to remember as well, there's loads of studies being done at the moment looking at healthy autonomous nervous system and its implication it has as long-term consequences, like decreasing the incidence of diabetes, Alzheimer, metabolic disease, or even atherosclerosis. So looking after the ANS of our babies, it also will improve the long-term outcome of our babies. And that was all. Thank you very much.
Thank you very much, Dr. Boa, for that very comprehensive presentation. Since this is an online presentation, I don't think we can entertain any questions. For those of you who are interested, the pain assessment machine that Dr. Boa showed on his presentation is available for demonstration in the trade stalls if you so wish to have a look at it. So we'll go on to the next speaker then.
We are now moving into the next topic, that is about therapeutic hypothermia and CFM monitoring. Let me introduce speaker. He's Dr. Surant Perera. Dr. Surant Perera is a consultant pediatrician at Casa Street Teaching Hospital for Women. He was graduated from Faculty of Medicine, Colombo in 1997. He obtained his MD in Pediatrics in 2009, and he became a fellow in Royal College of Pediatrics and Child Health in 2015. He is the past president of Perinatal Society of Sri Lanka and the past first president of the Perinatal Association of Private Hospitals in Sri Lanka. He is also the past secretary and council member of Sri Lanka College of Pediatricians and council member in Sri Lanka Medical Association. He holds posts in many other forums in Sri Lanka. He is a member of several national technical advisory committees of Ministry of Health in Sri Lanka. There are several book publications and research under his name. He's the one who initiated to bring down cooling machines and cooling machines and nitric oxide machines to the Sri Lanka. So may I call upon Dr. Surantha Perera to deliver his lecture.
So topic is therapeutic hypothermia. And this has come to forefront with the widespread use of cooling machines in Sri Lanka. We initiated project in 2019. The distribution phase completed in 2020, and then we are moving to data gathering and analysis and impact assessment over the next 5 years. So with that comment, I like to move to the key areas when we are talking about therapeutic hypothermia. The key areas are the introduction to therapeutic hypothermia, and then what about the cooling, the trial guidelines, what are the contraindications, the clinical assessment, how do we do, and then the amplitude integrated AEG, which is a very useful tool to monitor these babies, and it fulfills one of the criteria. And the structured approach is very important because mammals, all we know, their temperature is very stable. The fluctuation of temperature makes destabilize all the systems in the body, and so when we cool or when we initiate therapeutic hypothermia treatment, we have to make sure all the other systems function normally. So we derail one parameter, that is temperature, so we have to counteract the repercussions or the effects on the other organs. So we have to do a lot of interventions. We have to monitor. And this is the machine we have introduced. This is one of the machines being used at UK, some of the centers. And to highlight, this is where in Casa Street Hospital, one baby is being cooled. Just see the lot of gadgets surrounding the baby, and you can see a lot of probes going in, and one machine on the right side is made in USA. So they are the other counterparts who are producing good machines which are being used worldwide. If you look at the neonatal encephalopathy, incidence is 3 per 1,000 live births, and these are the statistics available from UK. And HIE occurs in half of them, 1.3 to 1.7. Moderate to severe, which fulfill the criteria for cooling, is occur around 1 to 1.5. The important thing is what the TOBI study, which was done some time back, which laid the foundation for the usage of therapeutic hypothermia, one of the proven, probably the only modality of treatment for perinatal hypoxia is with this study. So the issues, the risk of death or severe handicap, moderate to severe HI, is around 25 to 75%. So what that means? We have to monitor, follow up these babies and look for these complications. If you look at TOBI study, which was published in, there were several publications. One appeared in the New England Journal of Medicine. Background, they want to prove whether therapeutic hypothermia whether it has some effect. So what they did, they used therapeutic hypothermia on a selected population, dropped the temperature to 33.5 and continued over 72 hours, and which include the rewarming. So they surveyed these babies, followed up and evaluated over a certain period, and they found out they wanted to find out what will happen for these babies, and they monitor 12 neurological outcomes and some of the adverse outcomes also. So one of their population is 494 patients, and you can see there are 2 limbs 163 were supposed to undergo intensive cooling, 162 opted out. And ultimately the dropout is not much and is equal numbers. It may be difficult to visualize some of the words here, but what I want to highlight here is certain things which were seen seen as indications, like Apgar score at 10 minutes. Here it comes Apgar score at 10 minutes. Resuscitation continuing across 10 minutes, and clinical seizure which define B criteria. These are some of the things they have used as baseline characteristics of this infant population. Why I use this is this nicely shows how we do the therapeutic hypothermia. We continue to over 72 hours and we rewarm. You can see nicely it's been done. The baseline variations overlap one on each other. And this is very important. Main neurodevelopment outcome. I said they were looking for some of the parameters. You can see when you look at cerebral palsy, the p-value is less than 0.03. And hearing loss again 0.31. Here when you come to severe neurodevelopment disability 0.13. So p-value is significant. So the outcomes are significant. So we made an intervention, outcomes are significant. What it shows is this modality of treatment is beneficial for the newborns. And this slide shows adverse outcomes according to treatment groups. But you can see, what I want to show is, see the list of outcomes. I said this derail all the organs. You can see starting from the hypertension, coagulation derangement, drop in platelet, and intracranial hemorrhage. So it continues to cardiac and culture-proven sepsis. What were the conclusions? So the conclusion made was induction of moderate hypothermia over 72 hours is beneficial and significantly reduced the, although it did not significantly reduce the combined rate of death of severe or severe disability, but resulted in improved neurological outcome in survivors. That's the important point. So impact on the death is less because it is governed by some of the major insults happen perinatal period, and but the survivors, because the surrounding cells where the damage has happened, we can make them survive. So more cells survive, the more outcome and the better outcomes. The two important studies are the TOBI and CHD, and UK TOBI trial, one of them, and when we look at some of the filtered data, so there are 11 studies, those show again the neurodevelopment outcomes, and now this has become a standard, this modality of treatment has become the standard, which is supported by NICE, British Association for Perinatal Medicine. Clinical staging, all of you know, Sarnath described this in 1976, and there was certain modification over the years. And when you look at mild and moderate, the significant important thing is the occurrence of seizures differentiate, and this HIE classification is important, because then when we categorize, when we analyze this data latter part of a day, in future, we have to know what would be the outcome in HIE grade 1, 2, and 3. Especially 2 and 3, where most of these babies would be would have been on therapeutic cooling. So if you look at the box A, it's infants more than 36 weeks. Apgar score less than, these criteria, they have to be more than 36 weeks. That's the first thing. Second thing is look for dysmorphism. Look for any major structural anomalies. And those are relative contraindications because outcome going to be poor. So Apgar score should be less than 5 at 10 minutes and continued need of resuscitation at 10 minutes, and acidosis defined as less than pH less than 7 or base deficit more than 16. If you look at the box on the right hand side, the B category, neurological surveillance is important and the assessment, and they should have at least one of the following: hypertonia, abnormal reflexes, absent or weak suck, and clinical seizures. Nice to have AEG and the C category, and under that we look for one of the following: normal background with some seizure activity, moderate abnormal activity, suppressed activity or continuous seizure activity. But if you do not have a AEG facility, you should not withhold cooling. That's one. And the second thing is, all the machines we brought to Sri Lanka has this facility. And then video facility is also available. You can differentiate the AEG changes due to movement and AEG changes due to convulsions. Cooling outside trial guidelines. Because I felt like it's better to talk about this, because some of the babies fulfill criteria A and B, but between 6 and 12 hours. Are we going to cool only the babies less than 6 hours who are being affected, who shows neurological impairment? So the studies have shown, some have been published, will be published. It shows 6 to 12 hours group also, cohort also, if they are being cooled, they are benefited. And then the preterm infants. So we said the cutoff is 33. What is the benefit if we cool below 36? Then the next group, they have focus 1, 33 weeks, and then there are some benefits. And then acute postnatal collapse. And so is the certain times when the seizure continues, and then recurrent seizures, especially within the 12 hours. So these criteria are being evaluated. Currently has not come as the standard criteria, but some of the deaneries like West Midland and then some of the Black Country, these regions in UK, they have some of the babies have been randomized to these groups also, and outcomes are more favorable of inclusion of this cohort, these type of babies when you are thinking about cooling. Contraindications for cooling. So significant hemorrhage or thrombosis are some of them, and surgical conditions like significant blood loss and severe PPHs are others. And those are relative, not absolute. That's what you have to remember. Clinical assessment. Very important to switch off the resuscitator and then undergoing, continue to evaluate. And as I said, infants who fulfill criteria but not criteria based should undergo further neurological assessment during the first 6 hours. So that means there should be periodical evaluations. And if there's any doubt, best thing is to clarify with the senior. And this is the machine, tachotherm machine. And you can see the monitor, AEG monitor, and the cooling machine. Amplitude integrated AEG. This is the gold standard. This is the gold standard of knowing cerebral activity during this cooling period. So it comes as single or dual channel, and it should be recorded. It's a piece of evidence to show the baby has been affected, and it has to be attached to the BHT. One important thing is you have to remember is sometimes these babies are being paralyzed during the ventilation. It may facilitate better ventilation. And the second thing is these babies may be on some of the anticonvulsants to control convulsions. So this may change the AEG recording. You have to be mindful about that. So continual neurological examination using CFM is very important during the whole period of 72 hours. Sometimes you may see the apparent improvement, but this is not an indication to discontinue. And transient suppression of EEG we may be observed, as I mentioned earlier, due to anticonvulsant therapy. A normal EEG. This is a normal EEG. You can see, I mean, we come across different EEG tracings. You can see a baseline of 5 and 10 of millivolts, and then you can see the baseline and it has become bigger, and so this is abnormal EEG, and you can see here the spikes and it coming down to the baseline, and the baseline has gone up as a whole. It has shifted upwards. That's also abnormal. I use this photograph to show that X-ray features showing lot of attachments. There you can see the IV lines, you can see the umbilical venous catheters, as well as these probes can be put per esophageal or per rectal. Sometimes some are disposable, sometimes they can be used, but then it has to be per esophageal. This is an important graph we have come across during our initial training, not even during postgraduate training. You can see how the temperature manipulate this oxygen dissociation curve. Temperature shifted to the right hand side, what happened? The P50 goes up. So release of oxygen is impaired. So if the baby has a high demand of oxygen, it cannot be met. We have to keep the oxygen demand at a lower point. What influences the oxygen demand? The BMI. So we have to keep the BMI low. So the baby cannot move a lot. Moving means it demands a lot of oxygen. So we have to sedate and we have to paralyze. That's one thing you have to remember. And then proper ventilation is very important. It will also settle the baby. Ventilation. We have to have normal blood gases, and sometimes we have to use boluses to paralyze, and normocapnia is the target of achievement. And when we use the blood gas, we have to correct for the temperature of the newborn. And position is also very important, and we have to look for some of the features when we extubate, and position is very important. Already these babies are hypoxic, and those insults remain. And then if we do not position, the kinking of the veins happen at the neck level, and it further cut down the cerebral perfusion. Cardiovascular support, and that's a very important feature. And what I want to highlight here is, what is the heart rate of a normal baby? Normal baby in an intensive care setting, you will see around 150. But if they have a duct or if they are convulsing, it goes up. The numbers would be 170, 180. So if they go into cardiac arrhythmias, it may be 200 plus. But here the number is 80, 100. If you are a registrar in one of these NICUs, you will be alarmed to this. But cooling brings down the heart rate. What you have to notice, when the baby has distress, hypovolemia, the rise in heart rate. So it may come to a normal baseline, what we see in a normal baby. So this disparity, the caveat you have to remember. And when we think about blood pressure, you have to aim for, because we are cool in term babies. Term means 40 plus 5, 45 would be a safer mark. So hypertension is not really right for these type of sick babies, because it correlates with the cerebral perfusion. Fluids. When we give fluids, we have to restrict a little bit. So 40 to 60 would be fine. And then because already these babies have acute kidney injury, nephrons have been damaged. And so another feature you have to remember is overload. The initial period, what you will observe is oliguria. Later, they will have diuresis, and you have to know about it. Always ask about urine output, whether it has been measured, and if you can catheterize and measure, that would be fine. Another thing is, when you use doses, be mindful if you not to use like aminoglycoside, which are nephrotoxic, and then these drugs, because if you use in other countries, you have to decide about first dose and hold, or hold till the value comes. So you have to write it. You can't just prescribe gentamicin and go. You have to see whether it's below 1 or 2, and then other option is to use like medication like cefotaxime. And not only that, their metabolic function also derailed. One of the key element is normoglycemia. It is derailed, so you must make attempt to keep the blood sugar above 2.6. Analgesics and sedative, those are very important. And then when you sedate, as I said, BMI would be lower, the oxygen demand would be lower. And then the distress, how you recognize distress, you have to look for facial grimacing, irritability, and tachycardia. And again, you may confuse it with convulsions. So the finer knowledge of these newborns are very important, because during ward round, when I always emphasize one point is, Never deviate from your clinical science. Because we know always the PICU and the NICU will be dominated by numbers. But never forget about your basics. You must be able to spot few clinical signs here and there, extravasation, skin necrosis, and then what are the tubes contain, whether it is bilious, blood, and then the simple thing a lot, the parameters also. So it's a juggle between numbers and your observations. So there should be a finer balance in that. So non-ventilated babies may require morphine, and so the function should be monitored. And when we talk about machine, very important, all the nurses should be competent how to handle these machines. You know, sometimes shift to shift, there's a challenge. It's not the baby, it's not about our skill or the knowledge, it's the training we have given to the nurses. Sometimes they can identify certain issues with the machines, and then middle of the night we get stuck. It happens with high frequency oscillation, it happens with simple setting up CPAP, and when we use other machines. If you use gadgets, be thorough with it, and please learn to read the booklets. I don't know how many of you read a catalog belong to these machines. Right? When I work with some of my counterparts, they can dismantle a respiratory machine, ventilator machine, and they can assemble. That's their knowledge level, practical level. GIT. So when we are talking about gastrointestinal and the liver, again is another organ. You have to be very careful. Derailment can result in increased INR. Prothrombin time would be a fine reflector, as well as their enzyme levels goes up. We can use colostrum. It's simply available, and don't forget it. We can use it as a mouth care. It's very important. If you look at your web bundle, and so convulsing children, we have that convulsing bundle, and then the web bundle for ventilator-associated pneumonia. So frequent use of colostrum prevent occurrence of sepsis. And then think about drugs metabolized in liver. These things can accumulate. And seizures. So how do we recognize seizures? So reading of age is very important. And then when are we going to treat? One seizure, you don't have to panic and treat. And then when it's prolonged, more than 3 minutes, when it's frequent, we can use it, but correlate with the clinical picture and the other numbers. You know, very simple things. Seizures can happen because of lack of reducing sodium, glucose, or calciums. So make sure that these are available. Modern blood gas machines provide these things, including magnesium. What is the first line? We usually use IV phenobarbital, but what are the options? Now, levetiracetam and midazolam, all of us know, now has come to forefront. Levetiracetam is available, and the IV and the oral form. If unremitting seizure happens, we have to look for other causes, not to forget pyridoxine. Ask a simple question from the mother, whether she feels excessive movements latter part of their pregnancy, which may be the signs of convulsing child. Coagulation, very important, PT-INR. So we do PT-INR, it can be derailed or not, then we correct it using FFP. But make sure that you repeat 2 or 3 times, because first one may be normal, second, third would be derailed a lot. And then we have experienced some of the times intraventricular hemorrhages, slight hesitancy or slight misses would result in missing the value. Okay. And then the coagulation, one parameter observed in the TOBE trial. Infection, very important. What happened in the infection? When it is severe. Infection affect all the 3 cell lines. What are the cell lines? White cell count, and other thing is even the cooling. It brings the numbers down, platelet and the hemoglobin. So the hemoglobin also lost because of the frequent interventions. When the platelet is dropped, it can be due to early consumptive coagulopathy or because of the cooling. And the other side of the coin is, other important factor is, these remaining platelets also, certain percentage non-functioning, because the activity of the platelets also affected. So all in all, the more chance of the baby is getting infection. And initially, the CRP may behave differently, it may be normal, but you may observe later rise. And we are keen to know what type of infection affects our population in the Asian region. And it's very important for you to document in your ticket whether you have growth any organisms. Because what we want to evaluate is whether we see the same organism which affect the West affecting our population. And it's promoted with all the indwelling catheters and all the gadgets. And skin, very important. Please observe the skin is one of the largest organs, and look for breakdowns and extravasation, not to forget subcutaneous fat necrosis. Run your palm beneath the back, and then because babies are most of the time in the supine position, you may miss a significant amount of subcutaneous fat necrosis and the skin breakdown. Subcutaneous fat necrosis, if widespread, what does it cause? It may be associated with hypercalcemia also. And investigation, scan of the brain is very important, which is a very simply available tool. What are you looking for? I mean, sometimes very significantly affected, you may see some changes, but early changes you may missed. And MRI brain is more better tool. It has sensitivity specificity is very high. Late MRI brains would be really useful, but we don't have much facility. But if you have a teaching hospital close by, try to get the results. And it affects basically the watershed areas, which include thalamus, basal ganglia, and posterior limb. And you can see these images. The arrows are more focused, T1, T2 emitted in the MRI. Arrows are more focused towards the center, because those are the areas frequently affected because of the phenomenon of watershed areas. Finally, few slides. We are trying to get one of the cooling measures into these ambulances. What we strongly believe is we must be able to provide total NICU environment setting inside an ambulance. It would be good for all our trainees to see a unit with standard facilities, and so is the standard facilities that during the neonatal transport. Nursing care, nurses have to be honest and very empathetic when they communicate with these parents of these affected babies, and documentation should be clear, and they should do checklist, prognostication, neurological examination, AG findings, MRI findings are very useful to decide about it. And please, you have to please make sure that you write those things down. And reorientation. If the baby is significantly affected, think about palliative pathway, whether to resuscitate or not, whether to descale the therapeutic interventions. Finally, when the babies survive, when we send them back to the community, make sure they are being properly followed up at our neonatal clinics and at the settings of their home, closer to their environments. And very important to get the use of help of a development pediatrician. Finally, we initiated this project in 2019. We want to make sure these machines are available, especially cooling and the nitric oxide therapy, in equally distributed throughout the country. So we selected 15 level 3 and level 3 plus units. On 18th of September, we distributed these machines. It's one of the groundbreaking implementation of a national level project. The total cost of the project is 1.3 million euros. And very important, I always tell my registrars, SHOs, we talk about our problems. So we have to think about what are our solutions. So we bring vision to life. We need a change. We have to be the change. Thank you.
Thank you very much, Suranta. Shall we move on to the next topic since we are behind time? The last speaker for this session is Dr. Saman Kumara, who is currently the neonatologist in charge of the Castle Street Hospital for Women. Saman graduated from the faculty of Ruhuna obtaining his MD in 2004. And he had his overseas postgraduate training in neonatology in the United Kingdom. Dr. Saman Kumara has a competency certificate for cranial ultrasound scanning, special experience in neonatal echocardiogram, and is a qualified neonatal life support instructor for the Resuscitation Council in UK. He is the pioneer of who started nitric oxide treatment and therapeutic cooling in Sri Lanka for the first time at Castle Street Hospital. So I think we are very privileged to listen to Dr. Saman Kumara today, who will educate us on nitric oxide therapy. Over to you, Saman.
I'm going to talk about maybe another half an hour about nitric oxide. Nitric oxide is a life-saving gas. I call it that way. Why nitric oxide is so important? What is nitric oxide in first place? So nitric oxide was first identified as a gas by Joseph Priestley in 1772. And since then, there have been a lot of changes and a lot of studies with nitric oxide. And in 1998, the Nobel Prize was given for medicine for a team worked for with regards to nitric oxide. So it has a long story in terms of as a treatment modality in medicine, and especially in newborns. So it's a gas, remember, extremely important, extremely expensive gas. And also remember, it's imported to Sri Lanka. It's not produced, it's not available in Sri Lanka freely. It's imported to Sri Lanka from UK, Australia, or maybe from India. And that's why it's very expensive. And it is given through the ventilator circuits and mixes with inhaled or inspiratory gas, which goes to the baby's lung and reaches alveoli and then pulmonary circulation. So why should you use it? The primary reason to use is to reduce the pulmonary blood pressure when the pulmonary blood pressure is unnecessarily high. So it's the selective pulmonary vasodilator. So it relaxes pulmonary vascular smooth muscles selectively without affecting the systemic circulation. If you look at the diagram, very simply, and this explains all the reasons for pulmonary hypertension. If you start from top, we can have babies with renal malformation or premature rupture of membrane leading to oligohydramnios, causing pulmonary hyperplasia. And the baby has pulmonary hyperplasia and has pulmonary vascular hyperplasia. In addition to pulmonary hyperplasia, the baby has pulmonary vascular hyperplasia as well, which is in turn causes pulmonary hypertension. All right, okay. Right, okay, thanks. Then abnormal transition because of the asphyxia. Abnormal transition at birth because of asphyxia, acidosis, hypercapnia, hypoxia, all that causes pulmonary vascular vasoconstriction. And there can be intrinsic obstruction because of polycythemia. And this is the pulmonary artery, right ventricle and the right atrium. And this is the pulmonary capillary network and then pulmonary veins. At the lung level, there can be parenchymal changes at the lung, which causes secondary PPHN. The commonest is meconium aspiration syndrome and pneumonia, congenital pneumonia. And in addition, any reason, any cause which causes pulmonary venous hypertension, maybe as a result of pulmonary venous stenosis or mitral stenosis or left ventricular dysfunction, that also in turn causes pulmonary hypertension. So those are the basically main reasons for pulmonary hypertension, but out of all, we practically see in our day-to-day practice meconium aspiration syndrome as well as congenital pneumonia causing pulmonary hypertension mainly. So PPHN, when not treated, we all know it causes a lot of problems. It causes severe hypoxia leading to myocardial dysfunction and multi-organ failure because of severe hypoxia, and which in turn lead to severe systemic hypotension. When there's severe systemic hypotension, the right to left shunting, as you know, the right to left shunting can take place at the intracardiac level as well as extracardiac level through the patent foramen ovale or PGA. The right to left shunting gets aggravated, more severe shunting causing worsening of the right to left shunting, causing worsening of hypoxemia, and finally death. So this is a very common scenario. You get a baby with meconium aspiration syndrome, respiratory distress, you ventilate, and you can't ventilate, the baby is hypoxic, and then finally you lose the baby. Cause of death, very commonly you give meconium aspiration syndrome, or maybe sometimes mistakenly we give congenital heart disease. So secondary causes, as I said, meconium aspiration, congenital pneumonia, sepsis. The primary cause, without any lung pathology, they can still have severe pulmonary hypertension because of the primary pulmonary hypertension. That's an intrinsic problem with the lung pulmonary vasculature, which we call black lung disease. Right, so what happens when there's pulmonary very high pressure? Right to left shunting, severe desaturation, hypoxemia, worsening of pulmonary hypertension, severe hypoxia. So what about 2D echocardiogram? What are the changes that you can see in 2D echocardiogram? I think every place where we have nitric oxide now, in about 15, 16 hospitals, everywhere there should be, the facility should be available for 2D echocardiogram. The simple echocardiogram actually can be done by a pediatrician or a neonatologist. I think we all should learn that. And the changes that you see are, you can see dilated right atrium, and also tricuspid regurgitation. These are easily seen by 2D echocardiogram. And you can see patent foramen ovale with right to left shunting. And the intraventricular septum is very, very commonly seen bulging to the left side because right side pressure is high. And then you can see a nice PDA with either bidirectional shunting or right to left shunting. So these are the main features that you can see in the 2D echocardiogram in a baby with pulmonary hypertension. And if it is so severe, you can also see left ventricular dysfunction. So nitric oxide is a selective potent pulmonary vasodilator. As I told you at the beginning, there is no significant decrease in the systemic blood pressure. Trials have shown the need for ECMO, it reduces mainly about 40%. So if not for nitric oxide, the baby has to undergo ECMO. But by using nitric oxide, you can reduce the incidence of ECMO by 40%. So very important, as some of you are already having nitric oxide therapy available in your NICUs, and nitric oxide is not going to treat every baby with difficult oxygenation. So this is very important and should be used very carefully for selective patients only. You can't just throw nitric oxide for any baby who is desaturating or who is any baby who has difficulty in ventilation. The experienced neonatologist or a pediatrician should make the decision to start nitric oxide. And if you are not sure whether nitric oxide should be started or not, you should always contact somebody who has experience. We actually, I'm getting calls from everywhere now after starting this. I'm very, very happy to help. I'm getting calls from my trainees, juniors, and even the senior pediatricians. They are very, very decent, and they are contacting us for necessary advice when there's a difficult case to whether to start nitric oxide or not. I think that's really that should happen. Inappropriate use can cause a lot of wasting of money and also side effects. So one message I want to give, do not trigger pulmonary hypertension. The reason, not every baby born with meconium aspiration syndrome or congenital pneumonia or any other pulmonary condition has pulmonary hypertension. They can have mild degree of pulmonary hypertension, which can be easily treated with oxygen plus or minus respiratory support, maybe CPAP, non-invasive ventilation or invasive ventilation. But sometimes when you sit on the baby without giving adequate respiratory support in time, you basically push this baby to pulmonary hypertension and then get into trouble. So observation practice, this is my famous slide actually. Observation practice can be a killer. If you have a baby, a term baby, especially term baby who is coming from labor room or operation theater with mild respiratory distress or moderate respiratory distress, we have everywhere we have observation areas in NICUs. Before you admit, you put them on nasal prong oxygen or head box oxygen or face mask oxygen, and there's a practice of observing them. I consider it as a practice to kill babies if you are not very careful. And always when you have a baby with respiratory distress, maybe mild respiratory distress you might observe, but baby with significant respiratory distress, always you need to get senior opinion early. And mild distress with good saturation. I underline these two words. Mild distress with good saturation may be observed, but moderate distress, always offer them early respiratory support. Otherwise, you're wasting time and you're pushing the baby to develop pulmonary hypertension. And when you don't have treatment, you're going to kill the baby. And this is especially so with meconium aspiration babies. In my personal practice in our unit, we have no practice to observe babies with meconium aspiration syndrome in the observation area. Any baby with history of meconium, when the baby has respiratory distress, we offer them respiratory support early. So experience, I think this I have already told. So this is historic start of nitric oxide therapy in Sri Lanka. I will just cut short. I'm not going to talk about the whole story. It's a 35-year-old mother with 6 years primary subfertility. Unfortunately, these bad things happen to this kind of mothers, subfertile mother, and very, very, very innocent, very poor social background. They were actually very helpless couple. Became pregnant after IUI, and term baby delivered with a birth weight of 3.7, emergency cesarean section because of thick meconium, floppy baby, usual scenario, and a baby needed resuscitation, a bit of a bad resuscitation. APGA was 1, 2, 3 actually, and that was severely asphyxiated baby. And I'm not going to go into details about what we have done for this baby. I'm just going to rush in through. And this is the chest X-ray. This is typical meconium aspiration syndrome. You can see another line here. Suranta was talking about this. This is the same baby. We have started cooling also at the same time. And we did not have nitric oxide at this time. We had only cooling. So we were cooling and we were ventilating this baby. Typical meconium aspiration syndrome. So we have done everything, giving surfactant, high frequency oscillation, therapeutic hypothermia, and pre-ductal saturation was 95, post-ductal was 81. You can understand what's happening. So there's significant pre- and post-ductal difference. So basically, baby has already developed pulmonary hypertension, and we know what's happening. So much of things happen. Baby needed dopamine, noradrenaline, adrenaline, dobutamine, all the inotropes under the sun to maintain good systemic blood pressure and coagulopathy. And halfway through, we had to stop cooling because baby started bleeding a lot. So cooling was abandoned halfway through. We were struggling with MAP, and when the MAP was, this is something very important to note, when the MAP was dropping less than 60, we noticed baby was desaturating a lot. So why? Baby has to have a MAP above 60 to maintain good saturation, because the moment it drops below 60, there's right to left shunting taking place at the PDA level, making the baby more and more desaturated. That's a very common scenario. So over next 24 hours, baby was deteriorating, and the 2D echo, all the features were there with severe pulmonary hypertension. Pre-ductal saturation again 92 and post-ductal 81. We gave magnesium sulfate, which is and oral sildenafil, which was the only option available for pulmonary hypertension at that time. And there was anemia, baby developed convulsions. And day 3, preductal was 80, so baby was further going down, and postductal was 72. And we calculated oxygenation index for nothing, because by calculating oxygenation index, we are not going to do anything, but it was 57. 57 oxygenation index is absolutely high. Baby needs ECMO. And actually, I contacted Kapilani at that time, because we have to transfer the baby to Karapitiya. This baby is not stable enough to move from this bed to that bed, so sending to Kapilani was a dream. So we just forgot about going for ECMO. So we counseled the parents, and it was a very sad day because of all the background story. But unfortunately, I had to tell the parents that this is all I can do, and that was it. And then this was the first nitric oxide system, which was a donation from Dalada Maligawa, arrived at that time, immediately after counseling, because we were waiting for this machine came, and it has a long way to go again for training and installing the machine and all that, but that was done within an hour actually. I have to mention the name, Duminda from Technomedics. We had a massive effort to, we had so many Skype calls to Spain, and we put the machine and we saved this baby. So I have actually cut off a lot of story, and this is the baby now. He is 3 years. This baby is absolutely normal. So this is a magic gas. This is the difference that nitric oxide can do. Okay, so there was a recent story, a P2C1, 32-year-old mother, GDM on metformin, anomaly scan, normal anomaly scan by a experienced obstetrician, elective section done at 38 weeks of gestation, 3.6 kilogram baby, ABGA was absolutely normal, 9, 10, 10. I attended the delivery. Grunting since 30 minutes of age, NICU saturation 62, and nasal oxygen 2 liters. This is preductal saturation 62. And there was moderate subcostal recession, intercostal recessions. CPAP, started on CPAP, 6 centimeter water with FiO to 60%. There was no change, and chest X-ray was done. Then the venous blood gas at the time of cannula insertion was this 7.1 with carbon dioxide 68, and bicarbonate 12, and the base excess was 14, and the lactate was 8. And that's a chest X-ray. What would you do? What are we dealing with? This is a baby, term baby, otherwise normal, no risk factors, and develop respiratory distress, and there's mixed acidosis, and the chest X-ray. How would you treat? How would you label it? Anybody? Can you wake up from your sleep, please? What do you label it as? Pneumonia? No? Meconium? There's no meconium. I actually thought it's pneumonia. It's a congenital pneumonia, so I thought it's congenital pneumonia. I treated as congenital pneumonia because you can see the both lungs are affected, and a typical congenital pneumonia, and could be even streptococcal pneumonia possibility. Right. So intubated, and SIME, surfactant given. A dose of surfactant given, though it's a term baby because lungs were so bad, and saturation was sorry, this is going back. But there was no change with surfactant and ventilation. The saturation, no, FiO2 was 100%, postductal saturation 65 to 70%. So what's happening? What's happening now? So obviously anyone can think. So we are dealing with congenital pneumonia with severe pulmonary hypertension, and there was significant pre and postductal difference also. So repeat gas, capillary gas, 7.01, carbon dioxide 51, bicarbonate 15, base excess -12, and I did the echo at that time, and there was dilated right atrium, mild tricuspid regurgitation. Other chambers were normal, and great arteries were normal. There was a PDA. The pulmonary veins, I could not see the pulmonary veins. And this was in one of the private hospitals, actually. If this baby was born in Castle Street Hospital, I would have given nitric oxide with all these findings. But there was no nitric oxide in the private sector. So therefore, baby was not given nitric oxide, but I had a doubt. I had a doubt about the diagnosis of this baby. I was just thinking, I'm not dealing with straightforward congenital pneumonia. Anybody can guess the diagnosis? Kavilani? Yeah, absolutely. Because I could not see pulmonary veins, but seeing pulmonary veins is not very easy, but at least I could not see any pulmonary vein. So the urgent echo was done by the pediatric cardiologist, and we could not wait till 4 o'clock. We got down to cardiologist, and that was infracardiac type, obstructive, total anomalous pulmonary venous drainage. That's a typical X-ray of the condition. So that the learning point is echo is a must before nitric oxide. Otherwise, you would end up giving nitric oxide for all your critical congenital cyanotic heart disease babies and waste nitric oxide for nothing. What if the baby was born around 2 a.m. in the morning? There was no way of getting echo done, and no one is available to do arterial lines. And this kind of situation, if you have the criteria, if you have the X-ray features and pre- and postductal difference, 2 o'clock in the morning, we had a similar example at Castle Street Hospital. Then you can try, because otherwise what happens? You're going to lose the baby. So, but immediately you have to get an echo done and exclude congenital heart disease before you further proceed with nitric oxide. So similar case last week from Badulla, the same story, 2D echo done by cardiologist, adult cardiologist, and the PPHN was diagnosed. Nitric oxide commenced, and there was no response. The pediatrician was in constant contact with me. I don't know whether somebody from Badulla. There was no response after 24 hours of maximum therapy of nitric oxide. So whether this is a resistant case or whether this is another congenital heart disease which was missed by adult cardiologist is a question. So what can you do? So there was no response. 24 hours of therapy, absolutely no response. Then what you have to do is you should not continue and waste nitric oxide. You have to wean off. So wean off nitric oxide and counsel the parents. So this is a very famous slide in any lecture which talks about nitric oxide or pulmonary hypertension. This is the mechanism of nitric oxide. I'm not going to talk to you because I also don't know this. Absolutely, in really, right? You don't have to know this because this is practically, clinically not important. And there are a lot of studies which clearly indicates the use of nitric oxide reduces mortality and morbidity. Not going to go into detail again. So supportive care, you have to ensure a well-positioned ET tube with minimal leaks, and central venous access and arterial access also help if you can't get it, and correct metabolic acidosis with bicarbonate, and maintain pH of 7.35 to 7.45, and you may have to use bicarbonate to keep it in that range. And maintain good systolic blood pressure. If you are dealing with pulmonary hypertension, the target is at least 50 with all possible iron drops. You may have to use multiple iron drops to keep this systemic blood pressure going. Otherwise, patient will have right to left shunting. And aim for normal temperature unless cooling treatment is required. Electrolyte correction and magnesium, all these are important. Treat sepsis and strict fluid balance, and consider nutritional needs as well. And also remember, the less noise, less light, less handling, very important when you are dealing with baby with pulmonary hypertension, because each and every of these can trigger pulmonary hypertension. So how to start nitric oxide? First, you have to suspect clinically, calculate the oxygenation index, get the right radial artery puncture, and calculate oxygenation index, and confirm PPHN by 2D echocardiogram before you start nitric oxide. So exclude heart disease, assess pulmonary pressure, and also look at the left ventricular function, because when you use sometimes inotropes, milrinone is useful when you have a baby with pulmonary hypertension with associated left ventricular dysfunction. So that is something that you need to remember. So nitric oxide, you start with maximum recommended dose is 20 parts per million, and start as soon as possible without delaying it, because more you delay, the worse the prognosis. So start as soon as possible, and you should see the response within 4 to 24 hours of therapy. And the dose should be weaned off. You should be able to wean off the dose to 5 parts per million by about 24 hours of therapy. So you should not be continuing it 20 parts per million for days and days. And provided that arterial oxygenation is within adequate level with this 5 parts per million. There's no hard and fast rule. You may have to maintain 10 or 15, maybe a day or two. So signs of positive response when you start nitric oxide, generally you see positive response within 4 to 6 hours. Actually, the first baby I showed you, we noticed the pre and postductal saturation going above 96 within minutes of nitric oxide. So at least you have to wait and see 4 to 6 hours to see any response. So you will see improved pre and postductal saturation, narrowing of pre and postductal difference, and improved oxygenation index, and decreasing oxygen requirement, usually less than 60%. So nitric oxide should be maintained 5 parts per million until there's improvement in neonates oxygenation. So you can maintain 5 parts per million, couple of days even, but make sure that you try to reduce your oxygen FiO2 to a reasonable level, maybe about 40%, before you start weaning off further. So treatment can be maintained up to 96 hours until underlying oxygen desaturation has resolved. And the duration of therapy is variable, but generally within 4 days you should be able to stop nitric oxide. You can't be giving nitric oxide for weeks. But the first baby, I actually gave nitric oxide for 1 week. That's because that was our first baby. We did not have much experience, so we were very scared to wean off. Honestly, we were scared to wean off nitric oxide, so we wasted quite a lot of nitric oxide, but finally we saved the baby. So, but normally 4 days treatment is the standard treatment. So weaning, when to wean? As I told you, when the oxygen requirement is less than 60%, when there's good pre and postductal saturation, and when there's less than 5% difference in pre and postductal, you can start thinking of weaning. You wean with 5 parts per million at a time, and 1 to 2 hourly. You can make it 20, you can make it 15. If the baby remains stable, 1 to 2 hourly, you can come down by 5 parts per million until you are giving 5 parts per million. So when you are on 5 parts per million, then your weaning should be slower. Then you reduce it by 1 parts per million. Again 1 to 2 hourly until you end up giving the dose of 1 parts per million. So when the baby is stable on 1 parts per million with good saturation, and when there's no FiO2 is going back, then you can stop. But if the oxygenation falls more than 20% of your arterial oxygen, then nitric oxide therapy should be resumed at 5 parts per million, which means if the saturation is dropping and if the oxygen requirement is going up, then you have to go back on nitric oxide and start again 5 parts per million. And depending on the response, you may have to go up, or you may have to maintain 5 parts per million for another 24 hours. So non-responsive babies, as I told you, they should respond by 4 to 5 hours. Yeah, okay. Maybe 2 minutes. Even after deciding that, okay, this baby is not responding, you can't just stop. You need to wean off. So don't just stop. Right. And in clinical trials, there's no efficacy has been demonstrated with the use of nitric oxide in patients with congenital diaphragmatic hernia, but there's a literature. But there are some patients who respond. But post-surgically, most of them post-surgically, they have responded. So questions, I don't know whether they can allow any questions. I can take 1 or 2 questions. I'm sure you must be having questions, but as the time is running, sorry? Yes, lung collapse, any parenchymal disease can cause pulmonary hypertension. So pulmonary hyperplasia, lung collapse, and untreated pneumothorax, all that can trigger pulmonary hypertension. Any more questions? I'll give you 3 questions. What if you have to hand ventilate while on nitric oxide? So these are the practical questions. If you have to hand ventilate while on nitric oxide, what happens? So maybe desaturates, or you have to change the tube, or you have to do some hand embo for the baby. What can you do? Okay, answer is, you have the manual, go through the manual. There's a way that the nitric oxide can be connected to your ambu bag. Okay, so you can't just take the baby off completely on nitric oxide and resuscitate, because they can have rebound pulmonary hypertension. So you can continue nitric oxide through the ambu bag. Go and see the manual, the diagram is there. What about transferring a baby to another facility while on nitric oxide, maybe for surgery? Can we do that? That again a problem, because nitric oxide delivery system is not a transportable delivery system. But ideally, our dream is to have a transport system with nitric oxide, where we can transport babies while on nitric oxide. But there's another primitive system used by Indian people with all the flow meters, where you can still deliver nitric oxide while on transfer. Probably we will develop something for Sri Lanka in time to come. And can we use nitric oxide on CPAP and NIPPV? Those are the questions that should come up normally. I thought of putting these questions. Can we use nitric oxide? Not with the present system, but with modification you can use. There have been a lot of researchers, studies done with nitric oxide with NIPPV and CPAP. Okay, so take home message: never observe babies with significant respiratory distress. Offer them respiratory support early. Suspect PPHN, but confirm it before INO. And know the indications. Start 20 parts per million, but wean off, and slow weaning towards the end of the therapy. And remember, don't waste it. The 20-liter cylinder is 500,000 rupees. And we are using now 10-liter cylinders. It's about 250,000. Very, very expensive. So don't waste it. And if you run out of nitric oxide, take some time to get it down. So you have to use it very sparingly. Please don't waste it. Thank you.
Thank you, Saman, for that excellent lecture. I think we are well behind the time, so we have to wind up this session.